to participate in this series of webinars. So let me start sharing my screen. Yes.
Excellent. We can see your screen.
All right. So thank you again for the invitation. I will be speaking. I will be presenting the results of the report of the elective medication and procedure subcommittee of the Tearfilm Metographia Society, lifestyle epidemic and ocular surface disease workshop. So I have no financial interest related to this presentation.
Dr. George, if you could speak louder.
All right. So I was saying that I have no financial interest. To begin with, I would like to acknowledge all the co-authors and, of course, Professor Gomez, who was the head of this subcommittee. So all of these co-authors worked together to bring this report, and that has been published already at the Ocular Surface Journal. So in this report, we talked about the elective medications and procedures. So elective medications are and procedures are all that we do, all the medications and procedures that we do without a specific medical indication, without the need to do them. But patients undergo these procedures or use these medications just to maintain their healthy state or to benefit their quality of life. So it's something that they opt to do without a need to do it. So it's a planned or undertaken by choice with a lower grade of prioritization. Um, those uh, those elective medications or procedures can be local or systemic, and many of them may induce ocular surface disorders. So we try to use an evidence-based approach to evaluate the anatomical and biological impact of elective medication and procedures in ocular surface homeostasis, and to include a narrative review about the topical and systemic medications and procedures that affect the ocular surface. So we are going to talk about topical ocular, topical periocular, and systemic medications regarding medications. So it's those three categories. Topical and systemic medications and devices with potential effect on the ocular surface, as I said before, can be ophthalmic, topical, or periocular. This is a list that includes all of them, but we will go through them one by one. So topical, regarding topical ocular medication, ocular surface disease can be caused by toxicity of preservatives, toxicity of the ingredients, and toxicity of the excipients of the medication, the pH of the formula, tonicity of the formula, and of course, abuse of those medications. We know about the toxicity of preservatives. It's a very well studied subject. There is an allergic effect, a toxic effect, immune inflammatory mediated effect, and a chemical interaction of the preservatives with the tear film. The conjunctival epithelium, the nerves, and the meibomian glands. The benzalkonium chloride, it's basically has a detergent activity. It affects the lipid layer of the tear film, and of course it affects the mucus layer, so the stability of the tear film. It affects the goblet cells and the mucus layer, and also it affects the corneal nerves. So there has been studies that show that benzalkonium chloride reduces the sensitivity of the cornea, and also reduces the number of the density of the corneal nerve plexus, of the subepithelial corneal nerve plexus. So all drops that contain benzalkonium chloride can have this potential effect on the ocular surface. Regarding antifacial tears, The mainstay of treatment are those artificial tears. So we use them to reduce red redness, to moisture corneal surface, to wash out allergens, and obtain a regular surface during eye exams. And most of them has similar efficacies. But they have also side effects. They can cause blurred vision, burning, stinging, irritation at the time of installation, foreign body sensation, hyperemia, and allergic reactions. Sorry. Apart from the artificial tears, there are also some other complementary and alternative medicine that can be found today in the market, such as aloe vera, which is a herbal remedy. It facilitates wound healing and has antimicrobial properties. It is recommended for allergic disease sometimes, dry eye disease, and contact lens overwear, but it has also some side effects on the ocular surface, such as allergies, and it can cause ocular redness, irritation, and burning. Another type of remedy is honey eye drops, which is approved for the treatment of dry eye and over-the-counter remedy, which also can cause redness, stinging, conjunctival inflammation, and allergy if there is allergy to bee products. Antihistamines are also a category of medication that patients use over the counter. They can have side effects such as ocular irritation, hyperemia, burning, stinging, and visual disturbance, especially emendazine, and also mast cell stabilizers can also have side effects. Reported side effects are stinging, itching, burning, foreign body sensation, conjunctival chemosis, dry eye, and visual disturbance. The dual active drugs also have side effects. There are conflicting data regarding how much they affect the ocular surface, and they seem to be better tolerated than the previous mentioned. We know that lots of our patients sometimes use topical alpha-adrenergic receptor agonists to treat their allergy or to improve the hyperemia, conjunctival hyperemia. So those are drops. We can divide them in 3 generations. First generation includes phenylephrine tetrahydrozoline, second generation afazoline, oxymetazoline, and third generation brimonidine tartrate. So all of these, they have also the potential to cause pain, burning, stinging, irritation, and also the first and second generation mostly can cause rebound hyperemia, chronic toxic follicular conjunctivitis, blepharoconjunctivitis, and tachyphylaxis. So we need to let our patients know that if they use those drops, they can have adverse effects and they can have a rebound effect on the hyperemia that they're trying to treat. Non-steroidal anti-inflammatory drugs also are used by our patients, sometimes over the counter, to treat inflammation, but they can cause and allergic conjunctivitis, but also they have side effects such as conjunctival hyperemia, and they have they can cause burning, stinging, contact dermatitis, and it's very important to know that they have a local anesthetic effect, and all of them have the potential danger to cause a corneal melt, especially in compromised cornea, such as in patients that have diabetes. So we need to, when we give these drops to patients that our patients, we need to follow them. And also we need to let the patients know that those are drops with potential serious, very significant side effects. So this is a picture of a patient that had that did an abuse of non-steroid anti-inflammatory drops, ketorolac, and ended up, as you can see, with corneal melt. The other category of medication that of elective medication in topical is the periocular remedies, products that use in the periocular area, and they contain chemical, organic, or synthetic formulations, preservatives, buffers, and surfactants, fragrance, etc. As eyelid hygiene products, warm compresses, creams, and sunscreen, and medication for acne rosacea. Um, we need to know that a significant proportion of the population in studies have shown that has tested positive for allergies to fragrances that are contained on these topical and periocular um, remedies. Uh, Almost 4% of the population. The objective of these products is to reduce the burden uh, and help reduce the inflammatory response uh, of eyelid conditions such as blepharitis. So, tea tree oil and others such as linalool and hydrochlorous acid, aloe vera, and capryl has been used. I'm sorry. And but they do have adverse effects like discomfort, especially tea tree oil. We know that it can cause significant burning or stinging, and this is why we need to use a very low, less than 10% concentration, because more than this can be toxic for the ocular surface. Although the reports show that patients that have a compliance and use those can have a better quality of life and regarding their ocular surface. So, sorry. Sunscreens are used to protect from the damage from the ultraviolet radiation, but they can also cause irritation or pain, red eye, conjunctivitis, corneal abrasion, tearing, and blurred vision. And it has been studied in animal models that nanoparticles of titanium dioxide that are included and zinc oxide that are in sunscreens can have a cytotoxic effect on corneal cells. And also, so the ocular surface in dry eye disease can be even more vulnerable to these cytotoxic effects. And also, definitely, those can cause allergies to our patients. Topical steroids and ointments, they are used often to limit inflammation, but they can cause hypersensitivity reaction to preservatives. They can cause dermatitis, decrease wound healing, increase susceptibility to infections, and elevated intraocular pressure to steroid responses. So we always need to keep this in mind and inform the patients. This type of medication that is used for treatment of acne and rosacea, creams and ointments, like glycocalis, retinoids, and ivermectin, are known to increase tear osmolality, OSDI score, and cause punctate epitheliopathy, decrease tear breakup time, and also decrease meibomian gland function. Topical ivermectin can cause conjunctivitis, ocular hyperemia, burning sensation, and eye irritation. The other category are systemic medications. They can damage the ocular surface through several mechanisms by impacting the meibomian glands, lacrimal glands, and goblet cells, resulting in dry eye disease. Main mechanism subcategories include effect on innervation, vascularity, tissue metaplasia, inflammation, and neurosensory components of target organs. So, this table includes some of those medications that patients use by them sometimes in electively. So corticosteroids and NSAIDs are associated with conjunctivitis and blurred vision. Hydroxychloroquine can exacerbate dry eye disease and decrease um, tear production. Antimicrobials have the risk of Stevens-Johnson syndrome. There are several case reports. Omega-3 and 6 supplements have a beneficial effect on dry eye disease, but a high ratio of omega-6 to omega-3 levels should significantly increase the risk of dry eye disease. So we need to follow the patients that take these supplements. Vitamin supplements have been shown to cause neurotoxic effect in small fibers, and hormone replacement therapy, especially estrogen replacement after menopause, has been associated with increased dry eye and androgen deficiency contribute to meibomian and gland dysfunction. So anti-androgens can increase, decrease tear breakup time and increase tear evaporation. Tamsulosin also has been studied, I'm sorry, and have been shown that it can increase the risk of dry eye disease. Antihistamines and anticholinergics as systemic medication. There are studies that shown that there is a significantly higher dry eye disease in patients that take those type of medications. There are no systemic reviews, especially for cetirizine and pseudoephedrine. It has been shown that they can cause increased dryness because of reduction of tear production, and oxybutynin and tolterodine are associated with increased symptoms of foreign body sensation, eye burning, and dryness. And isotretinoin, there are several studies and also systematic review that shows that has significant adverse events in the ocular surface, can cause dryness, irritation, and conjunctival injection. Patients that take those medications are twice as likely to get this effect than patients that don't. Antidepressants and I'm sorry, and anxiolytics also has been studied, and they have an anticholinergic effect that reduces lacrimal gland secretion. Antivirals for chronic hepatitis also has been shown to cause common surface metaplasia and tear film abnormalities. Regarding surgical procedures and non-surgical procedures, basically, all of the procedures that we do in an elective manner. Procedures that target the eyelids and the periorbital region, such as eyelid surgery and other cosmetic procedures. We know that blepharoplasty, ptosis repair, canthoplasty, and brow lift, we do them for aesthetic purposes and also for maintaining a functioning eyelids and healthy ocular surface, but they can cause a damage to the ocular surface. They can cause corneal abrasion. When we do blepharoplasty, And when we do also, um, we try to reduce the fat prolapse. Sometimes we can cause lacrimal gland injury. We can cause chemosis to the oculars, to the conjunctiva, and also we can cause lag of thalamus, alteration to the blinking, and other side effects to the ocular surface. All of these can have a detrimental effect on the health of the ocular surface. Botox injections used for aesthetic purposes very often, apart from indications such as uh, strabismus and protective inducement of protective ptosis, etc. Um, they have very common side effects such as ptosis. They can cause a reduction of lacrimal gland secretion and dry eye, photophobia, ectropion, and transient tearing. So we need to be very careful when we do these injections. Um, Thankfully, these effects are not permanent. So if this happens, the next time that the patient will want to receive to get Botox injections, we need to um, uh, maybe give smaller volumes and be more careful where to give those injections in order to avoid these adverse events. Very common procedures lately are the cosmetic lasers, CO2 and YAG laser. They're used to treat uh, periocular wrinkles and some uh, other conditions. Uh, but adverse effects that are caused by this have been reported are pain. They can cause ectropion and skin complications, conjunctival hyperemia, corneal ulceration, and even bullous keratopathy has been reported. But all of this basically has happened in cases that there were not adequate eye protection or not the correct laser settings and not the correct usage of the laser. So with adequate eye protection and uh, good usage, the chance of these things happening is very low. Other elective procedures that are used periocularly are acupuncture and moxibustion. Reported adverse effects of these procedures is bleeding and hematoma, infections, local pain, and of course allergies and tissue damage. Uh, Even as you can see, the picture open globe penetration have been reported after acupuncture. So looking at conjunctival surgeries, pterygium is a very common surgery that we do. Of course, it's not always an elective procedure, but sometimes it's a procedure that we can do or not do depending on the patient's selection and what the patient wants, even for cosmetic purposes. And we know that the usage of topical mitomycin has been associated with uh, effect on the ocular surface and that can be detriment, even cause scleral thinning. Another procedure that has been lately used is conjunctivoplasty. This has been used for the whitening of the conjunctiva in cases of hyperemia with resection of the conjunctiva and tenoidectomy. So this is an elective procedure uh, that can cause, according to this report, necrotizing scleritis. So again, we see that these procedures should be used with caution to our patients. Going to refractive surgery, we all know that refractive surgery has a significant effect on the ocular surface. Dry eye after LASIK is almost universal in the early postoperative period. All of our patients will suffer from dry eye. 94.8 of the patients at the first day, and up to 60% of the patients 1 month after the operation, according to studies. Also, neuropathic epitheliopathy can be caused by LASIK. This has been described as a separate clinical entity to 4% of the patients and include a significant um, punctate epitheliopathy of the ocular surface. In PRK, things are a bit better, but again, there can be a significant effect on the ocular surface and dry eye up to 6 months postoperatively, 43% of patients. And of course, pre-existing dry eye and other risk factors um, can be predisposing for this effect. The mechanism of dry eye after LASIK and refractive surgery mostly includes the disruption of the nerves and also includes the damage to the goblet cells by the suction of the suction ring, the alteration of the corneal surface, um, and also the drops that we use postoperatively that can contain preservatives and also have an effect, as we said before, to the surface. So all of these three mechanisms with main the disruption of the nerves and the reduction of sensitivity, the reduction of secretion, tear secretion, and the reduction of blink reflex, all of these will cause a reduction of tear stability, a reduction of tear production, and significant dry eye. There is a debate if femtosecond laser versus conventional has a lesser effect on the surface uh, uh, femtosecond in comparison to the mechanical microkeratome. Not all of the studies agree that there is a low risk of dry eye when flap is created with a femtosecond laser. And in fact, there are studies that support the opposite, and they do not confirm the advantage of femtosecond versus mechanical microkeratome. Definitely, the advantage of femtosecond laser is that we can select the parameters such as flap depth and size, location of hinge, and the angle of the side cut, that also all of them have an effect on the ocular surface. A new procedure that has been gaining popularity the past years is SMILE. SMILE has a very smaller side cut than LASIK, so the opening of SMILE is about 4 millimeters in comparison to LASIK, which is almost 20, can be 20 millimeters, and this has been shown to have a less effect, less significant effect on the corneal nerves, so lesser nerves are cut, and this results to less significant effect on corneal sensitivity. So SMILE might have a better effect on ocular surface than LASIK. Of course, other procedures that cause ocular surface disease are keratoplasty, which is, of course, is not elective procedure, but sometimes it can be for aesthetic purposes and for patients that have non-seeing eyes with significant bullous keratopathy. And corneal tattooing, which also is a procedure that can reduce the aesthetic effect of bullous keratopathy or other scarring of the cornea, also has an effect on the ocular surface and the corneal nerves. Cross-linking, it has been shown that after cross-linking, the corneal nerves completely disappear from the subbasal nerve plexus for the early postoperative period. It can take up to 2 years to go back to return to the preoperative nerve plexus density. And also there is a significant reduction in corneal sensitivity after cross-linking. All of these, of course, as we said before, have a detrimental effect on the ocular surface. which is, for most of the cases, uh, temporary for the about 6 months after the operation. Also, there is an effect on goblet cell density and to the mucus layer of the tear film. Regarding lens surgery, so cataract surgery or clear lens extraction as elective, we all know that basically studies have shown that dry eye after cataract has been reported um, to vary from among studies from 8% to 42% 1 week postoperatively, and there is an improvement a few months postoperatively, but it can take up to 6 months, especially for patients with predisposing factors such as the diabetic patients. And the mechanisms that cause dry eye to cataract patients are, of course, the use of anesthetic, the intraoperative use of drops, the denervation that is caused by inflammatory factors, the goblet cell loss, the decrease in the lipid layer of the tear film after cataract surgery, the light toxicity from the microscope, and this has been studied also in vitro models. All of these, um, so cutting of the nerves with our incisions, the usage of the drops intraoperatively and postoperatively, the light toxicity of the microscope, all of these have a detrimental effect on the homeostasis of the ocular surface and cause dry eye postoperatively after cataract surgery. Um, the usage of femtosecond laser for the creation of the incisions and lens softening and the capsulorhexis. So femtosecond laser assisted cataract surgery seems to cause more symptoms than conventional surgery to the ocular surface, and this is because of the uh, um, suction that causes damage to the goblet cells, the docking um, of the laser. So although studies are not do not agree, uh, possibly we can say that flux can be a bit worse than conventional phaco for the ocular surface. Other surgical procedures, neurosurgical procedures, of course, those are mostly not elective, and bariatric surgery, which is elective, which can be elective. They also have complications for the ocular surface. Bariatric surgery can cause malabsorption of vitamin A due to vomits, food intolerance, and reduced gastric secretion and the detour of the intestinal absorption area. And of course, the vitamin A deficiency has a severe effect on our ocular surface. So, corneal homeostasis dynamics include the interaction between corneal nerves, neuromediators that assist the epithelium to regenerate. The epithelium produces neurotrophins for the corneal nerves, and the corneal nerves, um, let's say, have their effect on the tear secretion from the tear glands and the blinking rate. So this corneal homeostasis can be disrupted severely from the elective medications and procedures in all of the stages. And neurotrophic keratitis, this is another subject that is developed in our report. It's a condition we all know that is divided. It can start from punctate keratitis, in this more severe condition can cause persistent defects, stromal edema, and inflammation, and can end up to stromal thinning and even perforation. So this is a condition that we can see in patients that use these elective medication or procedures. And neuropathic pain is another condition that we need to keep our mind for our patients. This condition is divided in the mostly two categories: peripheral neuropathic and central neuropathic pain. Um, Peripheral neuropathic pain is caused by a primary lesion or dysfunction in the peripheral nervous system, and central neuropathic pain is caused by dysfunction in the central nervous system. There is a vicious circle between these two categories, and we need to keep in mind that this is a clinical entity that patients that complain for ocular surface pain and significant irritation, and we don't see um, signs on the ocular surface that can explain what the patient describes. This patient may suffer from neuropathic pain. So we need to keep this in mind, and it's a condition that can appear after procedures such as LASIK or cataract surgery because of the cutting of the corneal nerves and because of the suffering of the nerves after these procedures. And of course, pain can cause to our patients significant effects, impaired physical and social function, um, and can reduce significantly their quality of life. So going to prophylaxis from these effects. Um, we need to advise our patients, follow them, reduce or change medications that they use to different classes of topical medications, use corticosteroids, select the lubricating drops that best suit our patients, and reduce, of course, the exposure to preservatives. And of course, medical advice needs to be there all the time, and we need to be close to our patients always. Future research regarding this subject, we concluded in this report that we need more studies to have better understanding of the impact on the ocular surface of medication procedures. We need to improve our diagnostic tools and questionnaires in order to follow our patients better and explain their conditions better. And we need to improve our medications, instruments, and devices in order to reduce their side effects. So key points from this report. Several topical ocular and periocular elective medications and formulations can exert allergic, chemical, toxic, and immune inflammatory effects on the cornea, on the conjunctiva, the meibomian glands, and the nerves. Elective systemic medications such as isotretinoin, antidepressants, and others can affect the ocular surface through different mechanisms. Periocular cosmetic surgery and non-surgical procedures such as Botox, cosmetic lasers, acupuncture also can affect the ocular surface. And this depends on the location, the technique, and that we use while applying these type of procedures. Um, Ophthalmic surgical procedures can induce ocular surface disease, conjunctival surgery, refractive surgery, and cataract surgery can have a detrimental effect on the ocular surface, especially in patients with predisposing factors. So we need to inform our patients and maybe discourage them from undergoing these procedures if they have those predisposing factors. And maybe SMILE has less effect than LASIK because of on the corneal nerves and consequently to the ocular surface. And cross-linking can induce ocular surface disease. So it is important to stress that increasing the awareness of the potential risks, benefits, and consequences will help the patients to make the right decisions and while considering to undergo these elective procedures and medications. So this is our part. And so this is why we need to be informed about these effects. And thank you very much. I think I try to be as within the time frame as possible.
You did very well. Thank you. Thank you so much, Dr. George. I would take questions from the audience. So I'll just read the questions out and then you can go ahead and provide an answer. So the first question is around BAC, benzalkonium chloride.
Yes.
So the question is, it is said that BAC affects the tear film and the corneal epithelium, among other things. What exactly happens, or what's the mechanism of action by which benzalkonium chloride causes ocular surface disease?
So benzalkonium chloride is basically acts as a detergent, which means that it has an effect on the lipid layer of the tear film, and also it has an effect on the goblet cells. So it reduces the density of the goblet cells, and we know that the goblet cells on the ocular surface produce the mucus, so the mucin layer of the tear film, and also the effect on the lipid layer and the mucin layer. If we have those two layers damaged, then there is a reduced tear film stability and increased tear film evaporation. And apart from this, there is an effect on the corneal nerves. So there is patients that use chronically the benzalkonium chloride have reduced corneal nerve density. So with reduced corneal nerve density, reduced corneal film stability, and also there is an effect on the tight junctions between the epithelial cells. So the epithelium is not in a good health as well. So we have reduced stability, reduced tear film production because of the effect on the nerves. Maybe we have also reduced blinking or altered blinking because of the effect on the nerves. All of this together affect the stability and the health of the ocular surface and the tear film.
Thank you very much. So I think clinically we will be able to measure this by decreased tear breakup time or punctate stents.
Yes.
But how would you be able to tell, given a patient who presents to you, for example, how would you be able to detect that this is back toxicity you're seeing versus something else? I mean, if the patient is using multiple medications that are back preserved, I think it'd be pretty obvious. But how would you be able to tell otherwise that this is back toxicity in your
So
experience?
basically, if the patient is using medication with benzalkonium chloride and the patient is using chronically this type of medication, the first thing that you would think is that to remove it uh, from the patient remedy. I mean, if give them preservative-free drops, whatever the reason that our patients are using these the drops with the preservatives, there are options right now that we can give them preservative-free drops and see if the condition improves. That would be the first thing that you would do. You cannot tell if there is I mean, if the patient is using lots of types of drops for, let's say, for glaucoma, etc., then the first thing that you would do is to try to remove benzalkonium chloride and then see what happens and act accordingly.
Yeah. So I guess at the end of the day, it's sort of like a diagnosis of exclusion. You remove the back preserved medications and then see what happens to the ocular surface. You mentioned multiple medications and glaucoma, and I mean a lot of us who manage glaucoma with topical medications tend to see multiple signs of dry eye disease. And one of the medications you touched on was brimonidine. We know brimonidine has a vasoconstrictor effect, and it's been marketed, I mean, at least in the US, as Lumify in 0.025%. But from your slides or from your talk, you also mentioned how it can lead to rebound redness or conjunctival redness. So can you marry the two? Because it's sold for vasoconstriction to reduce redness, but it can also cause ocular surface disease.
So yes, it's not mostly the second generation agonists can cause but also brimonidine. So this goes because sometimes we tell the patients that we use these medications for maybe for once in a while or something, but when the patients uh, do it by themselves and they use them all the time, then if there is a rebound effect, then we just have there is no gain for our patients. So we need to let them know that they need to be careful when they use these, and they need to use them with caution and not make it habitual. That should be the message in these cases, in these patients. Um, uh, there are side effects with these drops, and with a rebound effect, then there is no gain at all. So this is something that all our patients need to know.
Thank you very much. So the next one is more of a comment or a suggestion. Saying basically saying how can TFOS ensure that safer preservatives are used. I know TFOS is not a regulatory body. We can only advise, we can do research, we can show this research to policymakers, like what we're doing now, enlightening people about how the some preservatives can affect the ocular surface and what safer options are out there. Um, the next question talks about what systemic medications, if given in childhood, may affect the color of the sclera in adulthood. Are you aware of any?
Uh, I don't think that I have an answer on this question. Do you have something in mind right now?
Yeah, neither do I. At the moment, I'm not aware of any, except maybe a systemic disease, maybe jaundice or something, but not necessarily a medication, um, as much as I remember. Um, So I think that's it from the questions from the audience. So I'll just go ahead and ask some of the questions that I did take note of as the presentation went on. I mean, there is the societal challenges report that talks about traditional eye medications and the eyes, and you touched a bit on aloe vera. Now, aloe vera is used in a lot of things. Can you tell us what are the what effect does aloe vera have on the ocular surface? I mean, aside from maybe some benefits, what are the detrimental effects of directly applying aloe vera to the ocular surface?
So more significantly, aloe vera can cause allergies. But there are also reports of other like let's say that the allergy would be the first thing that would be like worrying us. This is I think that patients allergic to latex um, can have also allergy to aloe vera. But the other reports about ocular redness, irritation, and burning, that patients suffer from ocular irritation and redness when they use aloe vera, and burning sensation, and this type of report. So um, I mean, this is what we need to inform our patients. Um,
All right, so thank you for that. My next question touches on NSAIDs. I mean, um, in my experience, I mean, sometimes I get patients referred to me for dry disease or persistent epithelial defects. or non-healing corneal abrasions. And the patient presents with having used NSAID drops for the past maybe duration of the onset. And a lot of times, I'm not sure how practitioners are aware of the anesthetic effect of NSAIDs, and sometimes the effect on delayed wound healing. So can you throw more light on how NSAIDs can impact the ocular surface, especially corneal wound healing? Because there was a case of near perforation that you showed, which was quite interesting. So can you talk more about that?
So because of the anesthetic effect, there is an effect on the blinking rate, the production of the tear film. There is an effect, as I showed before, the slide with the ocular surface. Let me go back to that slide. Homeostasis. So there is an effect. There is with it the NSAIDs basically is an example of how overuse of these drops can cause neurotrophic keratopathy because of the effect on the corneal nerves and the neuromediators and neurotrophins that are between the corneal epithelium and the corneal nerves. So there is a reduction in this, and because of this, we can have persistent epithelial defects, and there is a reduction in corneal wound healing, and there is an apoptotic effect on the corneal epithelial cells, and the mechanism also includes other like the reduced prostaglandins and the cyclooxygenase 2 activity. And all this leads to the degradation of the corneal stroma and to the corneal melt. Um, so it's the mechanism has to do with the action of the NSAIDs on the homeostasis of the cornea basically, and there are several reports of corneal melt after chronic use of NSAIDs. So um, the awareness regarding this it's very significant because it's a very common drop that we use after surgery, after refractive, after cataract surgery, and sometimes we use it in order to take advantage of this anesthetic effect, such as we do it after photorefractive kerato after PRK, to reduce patient's pain and increase comfort. But this needs to be always under careful patient monitoring
Monitor.
because the danger of the corneal melt may be not that common, but it is there.
I mean, now that you mention the use of NSAIDs with PRK, it makes you wonder sometimes. I mean, we know when we look at studies that compare ocular surface disease in LASIK versus PRK, we tend to see more with PRK. Is it the procedure itself or the things that we do during the procedure? Because sometimes you have PRK with mitomycin C, and then after the procedure, the patient has a bandage contact lens on with NSAIDs until the epithelium heals. Would you say it's a combination of the procedure itself and the treatments along with the procedure? How would you balance that, PRK versus LASIK?
So the most significant part of effect of these procedures on the ocular surface has to do with the corneal nerves. So by doing LASIK, we amputate the subepithelial nerve plexus while creating the flap, and then we ablate the cornea underneath. By doing PRK, we ablate the nerve plexus endings and a part of the subepithelial nerve plexus, depending on the depth of the ablation and the extent of the ablation, basically. And so there is a denervation of the central cornea postoperatively and a reduction in sensitivity, reduction in tear production, and reduction in blinking reflex. Apart from this, there is the effect of the drops that we use, intraoperatively or postoperatively. So we use anesthetic drops intraoperatively, and other drops we use, of course, our steroids, our NSAIDs in the case of PRK, we use the antimicrobial drops, and all of these drops very often contain benzalkonium chloride, and also they have their own effect on the ocular surface. So there is an additive effect of the drops that we use. Of course, the contact lens, as you mentioned before, the mitomycin maybe after PRK, if we don't apply it with caution on the ablated area of the cornea, and if we don't wash very thoroughly afterwards. So both procedures have many reasons to affect the corneal surface and the ocular surface.
Yeah.
Most of the studies agree that LASIK has a more severe effect, and this has to do with the amputation of the nerves, possibly. And an additive effect of LASIK is the effect of the suction ring, of the docking device of the laser, of the femtosecond laser, or the suction ring of the mechanical microkeratom on the
Yeah.
goblet cells of the ocular surface. So this is also
Okay.
an additive.
Yeah, thank you so much for that. Last question from me before I go back to the questions from the audience would be there's some areas you touched on, the effect of hormone replacement therapy on ocular surface disease, the use of tamsulosin for benign prostate hypertrophy and things like that. While as eye care practitioners, we may be aware that these sort of treatments or medications affect the ocular surface, it's also common practice to see that general practitioners or non-eye care personnel are not totally aware of these things. So what role do you think as eye care practitioners we can play in terms of making other specialties aware of such impact on the ocular surface when managing patients with these conditions?
So when we are aware of this, then we can discuss with the other specialists that treat our patients, and we need to let them know that from our part there is a significant adverse event in these cases on the patients, and maybe change the way they treat them if this is a treatment advised by another practitioner. So it is important to keep in touch with the other subspecialties and with the other practitioners that treat our patients, because we cannot change ourselves if this is a medication which has been given by another practitioner. We cannot change it, but we can inform the patients that they need to discuss because of this. So it is our part to grade the significance of the effect on the ocular surface, and give the feedback to the practitioner that prescribe this medication. I think this is the best way to manage these cases. And also, it is important for us to know that if we are treating these patients with our topical or medication, or maybe if we're planning a procedure, we need to know that if the patients are receiving this type of systemic medications for other reasons, such as acne medication, as we said before, this might change our plans, or means we might postpone the refractive surgery while our patient is under this type of medication, or we might treat them in a different way when they have other needs from ophthalmology. So it is very important that we need to know these side effects, and we need to know what our patients, what types of medication, systemic or others, our patients are using, apart from the whatever is related to their ophthalmic conditions.
Yeah, thank you so much for that. Your answer makes me think of sort of a possible area for research because it makes you wonder how many of these specialists who prescribe these medications actually know the impact on the ocular surface. So are you aware of any studies that have accessed the knowledge
Like a
or awareness?
questionnaire study or something? No, I'm not aware of this, but
Yeah,
it's
so I mean that would be something interesting to study.
interesting idea. Yes.
Okay, one of the questions from the audience is the rebound redness caused by brimonidine use, does it occur during the use of the medication or after? I mean, the redness can occur during the use if the patient is sensitive to brimonidine itself. The rebound redness you would see after you discontinue the treatment.
And there's also
I
the
think this question
tachyphylaxis after
touches.
the
Sorry, go ahead.
no, just the tachyphylaxis after the while using the brimonidine. So there might be a very quick development of tachyphylaxis sometimes some of the patients. So then we have no effect at all, and maybe
Yeah.
redness again.
So the next question I think touched on the question about discoloration of the sclera. The person gave an example of how tetracycline use in childhood can discolor the teeth. Are you aware of any medications? Again, I think the answer would still be no, but are you aware of any maybe antibiotics or any medications that can discolor the sclera in adulthood?
Um, in adulthood, you said.
All right then. So the next question is on the effect of applying garlic or onion fluid on the ocular surface. So I think we touched on this when we talked from when the presentation on the societal challenges came up regarding traditional eye medicines. But these kind of questions keep recurring because it's something that's common practice in the developing world, in India, Africa, some parts of Southeast Asia. So from
Greece as
your
well.
perspective,
It's not only
yeah.
we have uh, I have seen lots of patients saying that they have been using lemon drops. Let's say just putting lemons in their eyes. Garlic, as you said. So
Mhm.
this is something that happens in Greece as well. So
Oh, wow.
we have some experience of these cases, but
Yeah.
yes.
So what would you say would be the impact on the ocular surface? I mean, aside from the risk of infection, how would these things impact the ocular surface?
Well, first of all, the pH of lemon, I don't think it's something that would be
In,
compatible with ocular surface. And
Mhm.
I mean, I cannot say uh, definitely uh, using this cannot be compatible, like neither of these types of.
And there are some studies that show that they decrease the tear breakup time, they can increase risk of corneal perforation, risk of fungal keratitis, and things like that. So, I mean, when there are safer and sterile alternatives, I don't think we should be putting those kind of things in our eyes. I think that does it for the questions that we have today. And thank you so much, Dr. George, for being here, taking time out of your evening to spend with us and educate us on elective medications and procedures. Thank you so much. We're very grateful
Thank you
for
for the
that.
invitation.
Yeah, so if you could stop sharing your screen.
Yeah, let me.
Oh,
Hold on.
okay. So I think I've done it for you.
Stop. Yes. No, I did
All
it.
right, so you can see my screen now. All right, so once again, thank you so much. Just a reminder to everyone, look out for the emails regarding the practice survey from CFI. Would like to know how dry eye management is done where you practice. The recordings for the webinar would also be made available on the iAfrica Media YouTube page. So look out for that as well. And if you have further questions or you'd like to talk more to Dr. George about the presentation, you can email him, and I'm sure he'll be glad to respond. Thank you so much, everyone, for joining in. So tomorrow, we're going to be taking a break, and we would resume on Monday with Professor James Wolfson, who will be talking about the impact of the digital environment on the ocular surface. Once again, thank you so much, everyone. Thank you so much, Dr. George. Enjoy the rest of your night.